Hello, I'm Annemieke Aartsma-Rus. I'm from the Leiden University Medical Center, and I'm very sorry that I cannot be with you in person today because, well, if you know me, you know that I love Israeli food. I also love your country. I love the weather that's often much better than the Dutch weather. So I'm very sorry that I cannot be with you in person. But it's great that I at least can contribute in this way to your virtual conference. And of course, congratulations to the 10-year anniversary. And I would like to commend you also for all the nice work that you have achieved in the past 10 years. So what I will do in the next 10-15 minutes is to introduce Duchenne, dystrophin, and also the way that different therapeutic approaches can try to improve the pathology of Duchenne. So these are my disclosures. And Duchenne is of course caused by lack of dystrophin. And dystrophin normally stabilizes muscle fibers when you use your muscle. And of course, there's a lot of forces that come on the muscle when you use them. And dystrophin prevents these forces from causing damage. And it does that by connecting the inside of the muscle fibers to the outside of the muscle fibers. You can compare that to this carabiner system. And the way that the carabiner system works is you don't need this to go rock climbing. You need this to avoid damage when you make a mistake. Well, this is the same thing with dystrophin. You don't need dystrophin to use your muscle. You need dystrophin to avoid that things go wrong. And if you use your muscles without dystrophin, things go wrong all the time. And we know this because Duchenne patients don't have dystrophin. And even when they use their muscle in a normal way, they continuously have damage. And that is because this linker function is lost. Now there's also Becker muscular dystrophy, and here patients make a shorter protein. But what you can see is that with dystrophin, the connection to the rope is lost. So if you fall, you crash. In Becker patient, both connecting domains are there, only the elastic bit in the middle is shorter. That means that if you fall, it's uncomfortable, and you may bump against the rocks, but you will not crash. And this is the same in patients. Duchenne patients have a very severe disease. It's progressive, while Becker patients have a less severe disease that is less progressive. And I don't want to trivialize Becker. It's still a severe disease, but compared to Duchenne, it is less severe. So now we can go into what happens when there is no dystrophin. And the first thing I already mentioned, if there is no dystrophin, patients will get muscle damage all the time when they use their muscle. Now, normally, having muscle damage is not a problem. Also, healthy people can sometimes have muscle damage, but that is then repaired. However, this is a process that happens sequentially. So when there's muscle damage, first you have inflammation, which then clears away all the rubbish, and then you have the repair. Just like if you refurbish your kitchen, you take out the old kitchen first, and then you start building your new kitchen. You're not gonna put in new cupboards when the old ones are still there. So this happens in the same way with muscle repair. However, because Duchenne patients have damage all the time, there's always inflammation somewhere in the muscle. And that means that even the areas where there should be repair, there is no repair because the inflammation inhibits the repair. So that's one problem. There's an inhibition of the repair. There's also chronic inflammation because there's damage all the time. And when there's chronic inflammation, this will mean oxidative stress, and this will mean that fibrosis is formed. So rather than having new muscle, you get scar tissue formation. And once there is fibrosis, so once there is this scar tissue, this tissue produces factors that further inhibit repair. So you can already see that things go wrong continuously. Now, another thing, if there is no dystrophin, is that there's less blood flow. And if there's less blood flow, that means more muscle damage, because when you use your muscle, you need the nutrients, you need the oxygen. When this is not there, you get more muscle damage, you get oxidative stress. And again, you get more of this inflammation, fibrosis, and less repair. Now, finally, there's too much calcium ions in the skeletal muscles due to lack of dystrophin. And this means that there's less energy production because The power generators of the cell, the mitochondria, are very sensitive to how much calcium there is in the muscle fibers. Because there's less energy, there's more oxidative stress, there's again more damage. So all these pathways jointly contribute to a continuous loss of muscle tissue and loss of muscle function. And this is what happens in Duchenne. In Becker, this happens as well, but at a much slower pace. So then how can we address the pathology? How can we interfere with this? Now, one thing is, of course, what you can say, let's target inflammation. So we see here inflammation. If we would reduce inflammation, we expect that there's more repair. We expect that the oxidative stress will be less, that there will be less fibrosis. We're not going to counteract everything, but at least we may slow down part of the pathology. Well, suppressing inflammation is, of course, already done. So almost all patients take corticosteroids. Corticosteroids work in multiple ways, but one of the things that they do is that they inhibit inflammation, and that is probably their main reason for slowing down disease progression in Duchenne. Corticosteroids are not approved for Duchenne. They are used off-label. So we know that they inhibit inflammation, and we know that they can slow down disease progression. They're in the standards of care, but they're not specifically registered for treating Duchenne. So they're used off-label, but by almost all patients. The problem with chronic use of corticosteroids is, of course, all the side effects. And that's why a new drug is in development called vamorolone. And the hope is that this will do the beneficial aspects of the corticosteroids, but with much less side effects. And whether that is indeed the case, we don't know. It's in trial so far. Studies are encouraging, but more work is really needed to see whether it can give the same benefit and whether indeed there are less side effects. So this is being studied currently in studies, clinical trials in Europe and the US. Then there's another compound called adasalonexant, and that is very specifically targeting the inflammation. And unfortunately, we heard last week, last week when I taped this, so end of October, we heard that unfortunately the clinical trial did not show benefit. So this development is stopped, and this again shows that the steroids do more than just acting on the inflammation. So unfortunately, this development has stopped. And we'll have to wait and see what the vamorolone brings. Hopefully it will do the same as the steroids without the severe side effects. Now, of course, there's other areas you can interfere. You can also interfere with the oxidative stress and the fibrosis formation. And oxidative stress, I mean, antioxidants, we all know them. Green tea has antioxidants. The problem is that if you really want to have an impact, you would have to drink liters and liters and liters of green tea. Well, that's not going to work. So there are more potent antioxidants. And these have been tested in Duchenne as well. One of them is called idebenone. And also here, unfortunately, in October, we learned that there was no benefit in a phase 3 clinical trial. So this development, unfortunately, also has stopped because this was not sufficiently efficient to slow down disease progression in Duchenne. There's also another compound in clinical trials that's called pamrevlumab, and this is an anti-CTGF antibody, and so CTGF is a very important player in fibrosis formation. So the hope is that if you inhibit this, you will slow down fibrosis. A phase 2 clinical trials ongoing in the US. We don't know yet whether this will have an effect or not. We will have to wait and see for that. Now, the challenge is that if you target just one part of the pathology, all the other things will continue. So then, of course, it would be better to target different areas of the pathology. Well, there's one compound that aims to do that. That's called givinostat. Here, the repair should be improved, inflammation should be reduced, and fibrosis should also be reduced. Whether that is really the case, we'll have to wait and see again, because this is currently tested in a phase 3 clinical trial. So we'll have to wait and see whether indeed this has effects on repair, inflammation, and fibrosis, and whether also slows down disease progression. So we'll have to wait for that. Now, of course, all these pathways occur because there is no dystrophin. So if we could restore dystrophin, all these downstream pathways would be slowed down. So that is maybe a more effective way. And there's different ways that therapies that are in development now try to address this. There's exon skipping, there's stop codon retro, and there's gene addition, and all these three are in clinical trials. And there's also genome editing that is in an earlier stage, and that will be covered in another lecture. So I'll now explain exon skipping, stop codon retro, and gene addition. Starting with exon skipping. So we have the blueprint of all the proteins that we make in our genes, including the dystrophin gene. And the genetic code of the protein is dispersed over parts of the gene. And these things are called exons. So the exons contain the genetic code. In between, there's parts of the gene that do not contain the genetic code, don't code for protein. They are called introns. Now, when a protein needs to be made, first a temporary copy of the gene is made, called RNA, and that contains both the protein coding information and the non-coding information. And before this code is translated into protein, these non-coding pieces need to be removed. So all the exons, the coding containing information pieces, are linked together in a process called splicing. You then end up with your messenger RNA containing only the code, which is then translated in the cell into protein. And this is currently happening for all our proteins in all our cells. Now, what you could see is that these exons are like puzzle pieces and they all fit together. What happens in Duchenne patients is that most often one or more exons are missing, and that then the puzzle pieces don't fit. So you see here, exon 48, 49, and 50 are missing, and 47 and 51 don't fit. And then we say the reading frame is disrupted. The code becomes unreadable because the cell can translate until 47, and here the code becomes unreadable, so translation stops. And this is why the dystrophin is not functional, because only the beginning part is made, and this link, the important last domain that needs to link, is not there. So these are the Duchenne mutations. Now in Becker patients, what happens also often, one or more exons are missing. You see here 48, 49, 50, and 51 are missing, but now 47 fits to 52. So the code is readable, the frame is not disrupted. So that means that the translation can continue. There is a little bit missing here in the middle because some of the coding pieces are missing. However, the crucial part of the dystrophin at the beginning and the end, these are there. And this is why Becker-like dystrophins are partially functional. Now, the idea of exon skipping is to allow Duchenne patients to make a Becker-like dystrophin. And again, here we have this temporary copy with the exons and the introns, so the coding parts and the non-coding parts. And what we see is 51 doesn't fit to 47. We've seen that already. And what we also know is 47 would fit to 52. So what we want the cell to ignore this one, exon 51. And we can do that with antisense oligonucleotides, or AONs, short pieces of modified RNA that bind specifically, in this case, to exon 51, hide it. Now 47 is joined to 52, the code is restored, and the cells can produce a Becker-like dystrophin. So where are we at with exon skipping at the moment? Well, first of all, this is a mutation-specific approach. So depending on your mutation, the size, the location, you need to skip specific exons. There's currently 3 AONs approved, 1 for 51 and 2 for 53, and they are approved in the US and Japan only. This approval is based on dystrophin restoration and very low amounts of dystrophin. So less than 1% to about 5%. And I always say some dystrophin is better than none, but with these low levels, the question really is this enough to slow down disease progression? And that is something that the companies that develop these AONs, they still need to show. They need to show the regulatory agency that indeed this has functional consequences, and the clinical trials to do this are currently ongoing. Now, what is clear is that we need to improve these AONs. There's room for improvement. So there's also work ongoing on trying to make better chemistry, to improve the delivery to skeletal muscles. And this work is ongoing, but the problem here is that these are using new chemistries. And then, of course, we don't know whether these will be safe in humans. So that is then the thing that will still need to be discovered. Now, the second thing I will talk about is stop codon read-through, and this applies to very specific mutations. So again, here we have this messenger RNA, the code for the protein. It has a start signal, so the translation machinery knows I need to start translating here, and at the end it has a stop, so it knows protein is complete. Now, what is possible is that the code has a very minor change, whereby the code for a protein subunit is now converted into the code for a stop. And this will be used, and then of course only the beginning of the protein is made. However, the rest of the code is still intact. Now, there are compounds that can suppress the use of these fake stops that shouldn't be there, but due to a small mutation are there. And one of these compounds is called ataluren. And again, I want to show here that this only works for these nonsense mutations. So here again, we have the start, we have to stop, and now here, the only change that happens is that suddenly here we have an extra stop. If we have these mutations that disrupt the code, so the frame shift that make the code unreadable, this will not work because the code will still be unreadable. The ataluren doesn't change that, it only suppresses these type of mutations. Now, what is the current state of the art of this ataluren, this stop codon read-through compound? It is conditionally approved in Europe for ambulant patients of 2 years and older. Conditional approval means that every year it's re-evaluated. Is it safe and is it still effective until the company acquires enough information to get full approval. It's marketed in several European countries. I know it's marketed also in Israel, but it's not available everywhere. So for instance, it's not yet available in the Netherlands. There's trials ongoing because it's conditionally approved. The company needs to collect additional information to show that this indeed has also functional effects. So there's several trials ongoing. And in addition, the patients that are now treated commercially with this drug are also being followed and data is collected from them. And so far the results look encouraging. So again, we'll have to wait and see, but for now, at least this is available. Then finally, gene addition. So the dystrophin gene is not functional in Duchenne patients. Can we give them a copy of the dystrophin gene that is functional? And yes, we can do that, but the problem is, how do we deliver that gene? Well, for this, we need to use viral vectors because viruses do nothing more than delivering their genetic information to human cells. Now, the problem with viral vectors is that most often they do not infect skeletal muscle. There is one exception, and that is AAV, adeno-associated virus. AAV does not cause disease, so that is a good thing, but it's a very small virus. So it has a limited capacity for how much DNA you can put in. Unfortunately, the dystrophin gene is the largest gene that we know. So what we need to do, we need to make a very short dystrophin. So what several researchers have done, they've generated a microdystrophin. So in a minimalistic approach, they have made a dystrophin that contains only the crucial domains. And again, if we have our carabiner, so we know this is important and this is important. So this bit here corresponds to this, and this bit here corresponds to that. And you can see here these 3 microdystrophins. You can see that they have these important domains. And then in the middle, the elastic part, that varies. So there's currently 3 companies, Solid, Pfizer, and Sarepta, and each of them has a slightly different microdystrophin that of course all has these crucial domains. And these are currently tested in clinical trials, and you will hear more about that in this session. So in summary, Duchenne and Becker are both caused by dystrophin mutations. The therapeutic approaches that are used or are in the clinic now for Duchenne are corticosteroids used off-label, ataluren in Europe only for nonsense mutation, and exon skipping only in the US and Japan for other mutations. And there's also a lot of therapeutic approaches in development. Some that try to address the pathology, and these you can use for both Duchenne and Becker, and some that try to restore the dystrophin. And then it's always a partially functional dystrophin like Becker. So this would only apply for Duchenne. So thank you very much. And if you have any questions, then of course, I'm happy to answer them later in the Q&A session.